All right, and when you see his feet, he has a flared right foot, he got a short right leg. Why do I think he's got a short right leg? Well, he got a low right hand. So his foot is flared. Okay, a foot, if I'm falling to the right, my foot goes, oh, be careful. Oh, you're falling. Oh, my foot flares. So innately, without him knowing it, his foot is flaring to the right because he's out of alignment to the right. All right? Low shoulder on the right and a high ear. This is a surgeon who spends hours over the table with corrective surgery. More than likely, like chiropractors, adapt to a certain side or another better than one side or the other.
Sure.
Yeah, right-handed, left-handed, right?
Yeah.
Applies in surgery. We need him. He just fixed me like miraculously at L4, L5. We need him. We have to help him last a long time. He'll wear out a hell of a lot slower by getting GPA and keeping him balanced than not. Okay? All right. Face down for me, sir. Woo! Here we go.
Yeah.
Dr. Jancy is smiling at me. Hi, Dr. J. All right. Yes. All right. Leg lengths. The right leg is about 3/8 of an inch shorter than the left. And when I bend his knees, I got a 1/2 inch. Okay? So we have a short right leg. We have a pant line right here that deviates a touch to the right, meaning that the right pelvis lower than the left pelvis. Do you want to feel that, Doc? Do you trust me?
I trust you.
Okay. Low, high. So here's this glute muscle here, and you have a flat glute muscle here, not because the muscle's bad, because the pelvis has taken the muscle forward, so it's less prominent. All right? Tender?
A little bit.
S4. Tender?
Not so much.
Okay. S2. L5?
No, it's okay.
Okay. Okay. L5? Transverse process?
Yeah, a little bit.
A little bit. Different than L5 transverse process on the right?
Yeah.
Yeah. Okay, in palpating here, there's a gap here. You can see my fingers go in. Close up on that, Jerry.
Mm-hmm.
But over here, it's high. So the vertebra, L5, has rotated left posterior, where I feel more pressure at L5, and it's not severely painful, but it's certainly different than here.
Yeah.
Okay? So it's my opinion that I have to correct this, correct the feet, and balance this out so to start with, this isn't here. Before I do that, lift up. I put the wedge not under the spine, not under the hip, under the pelvis. I believe the anterior pelvis is right. Okay, so by rotating the pelvis, will that encourage L5 to shift anterior? Different?
Yeah.
Yeah. Okay, so by raising the right pelvis, I encourage fifth lumbar to shift. Can I leave him here? Well, you can do a lot of passive stuff. Patients at home, you figure this out, people at home, instead of going whatever. Okay, you can use, I don't want you not to go to a chiropractor, but I want you to go to the right chiropractor. You can use different wedges with your shoes or whatever and balance you out. Say, gee, that feels better. Let me lay there for 10 minutes and breathe, and my sacrum and occiput will start fixing itself. Yes. All right. So we know that helps. So this, we know this was anterior. When we make it posterior, it takes pressure off of fifth lumbar. Well, now he's even. All right, let's check the feet. Feet are good. So his pedal foundation is good. I checked the calves. He's flaccid in the left calf, and he's strong in the right calf. You feel this, Doc? Loose, kind of soft, strong. He's flatter in the hamstring, bigger in the left hamstring. So he's out of balance. So what I'm going to do, bypass the foot right now, because I don't find anything right now. Put this wedge down. Assisted drop. You feel I'm barely touching you? Can you tell that?
Mm-hmm.
Okay. And then I fix the pelvis. Did you do that scissors work,
Yes.
Doctor? What you want to do at L5 is scissor it down with your thenar. You come down. You don't push it. You rotate it.
And to get that mechanism that Dr. Vetanze just said, I'm going to stand back a little bit, so my body, so when I come down, I'm automatically coming down to the side like you described.
Okay. All right, now, no wedges, no anything. Let's go back to sacrum 4. Any pain?
No, it's not good.
Okay. L5 on the left. Anything?
Feels better.
Feels different than it did before and better. He says it feels better. He had a little pressure there before, probably some mild discomfort. Okay, I felt it being posterior or rotated, so I just rotated it back in position. So we did this before we did the feet. Let's see what happened to the feet. Now the right leg is almost an inch short. Okay, now when I lower the legs, I even up about right here. Watch the heels, Jerry. You got them? Okay, now watch when I do this. You see it start shifting. Okay? So we're stuck at about a ½ inch, 3/4 inch short in the right leg. Doctor, please turn your head to the right. Oh. And left. And turn it to the right again. This is very interesting. When he turns his head face down, thank you. When he turns his head to the right, I felt the whole pelvis shift and the leg shift. Doc has a fixation, upper cervical, and occiput. But it's shown itself now. But we're following a pattern, right? So, okay. Turn your head to the right. Bingo. Keep your head there. So we keep his head there. Cock the table. And we just separate it face down. Okay. That wasn't very hard, Dr. Vetanze. This is not about hard, because the body's telling me you're ready to do the occiput and you're ready to do the sacrum. I don't have to do it hard. You just tap it. Occiput and sacrum and Desjardins and Jancy, you're saying, thank you. Okay? So now we come back and the leg lengths are perfect. Okay, now watch the feet. You got them, Jared? Turn your head right. Nothing. Turn your head left. Nothing. Face down, sir. Boom. So, doctor wasn't having a lot of issues, but I just made a step in the right direction to prevent him from having some issues, because he's important to us. We have to have him out there saving lives. Might have been a minor thing. Occiput was locked up. He has a one-sided profession. At the same time, the table, you kind of develop right side or left when you're a chiropractor, surgeon, whatever, you know, your right hand, left hand, or whatever. Fix the pelvis, okay? Leg lengths are even. The feet look good. All right? On your back, sir. Has anything hurt yet?
No.
No, okay. You know your grandfather was the greatest human being that ever lived. I'm just telling you, you got a hell of an actor follow-up. He was phenomenal. The best human being, the best leader of chiropractic. Wasn't for him, I don't think we'd be here today. As a chiropractic profession. Okay, I just wanted you to know that. Would you lower that for me, please? I'll get that in. Okay. Bend your knee, sir. All right. I like to wobble it, but let it set. 90 degrees, internal rotation. 90 degrees, internal rotation. You're what, 30?
41.
You didn't have to tell all these people. You're a kid, right? We got 10 degrees. And it's interesting. I have a rubber band effect and also a wall effect. If I go here, I get more rubber band. If I go here, I get bone to bone. Something's going on in this hip. Then this. Restricted, but more of a rubber band effect, right? So I have a restriction in both hips. So I'm saying to myself, they weren't painful when I did that, were they?
No.
Okay, I'm saying to myself, I think the pelvis is shifted, the whole pelvis, causing bilateral restriction of range of motion, mostly functional, not structural. So I figure if I can change the lordotic curvature and shift the pelvis with a little bit of a drop, then I can help the rotation of the hip and prevent degenerative arthritis or future problems. Would you bend your knees and lift up? Let me put this under your sacrum. Right there. Okay, so I put the wedge this way. So I'm trying to take away the lordosis of the lumbar spine, shift the pelvis posterior, all right? And change, when I shift the pelvis posterior, the head of the femurs will rotate and get to a better position they want to be in to function better for him as a biped. Okay, you bring both knees up like here. A couple ways to do this. Me, I want to shift the pelvis. Okay, if I wanted to shift the pelvis and take it the other direction, I adjust the pubic bones. That'll be, boom, this type of shift. If I want to shift the pelvis backwards and take away the lordosis, I want to do the anterior superior iliac spines. I shift the ASISs. I felt a move. Okay? Now, you can make me a truth or a liar. I don't know, see what's going to happen here. So this is the hip that was 20 degrees. And what? How did I do that? Okay, this was 20, now it is 70. This is one of the major adjustments when the professional athletes come in, and so many of them have no internal hip rotation. All right? And then when I do that, they go, what? I says, get here, be here all the time. And they do. Bend this one, and a little bit stiffer on this side. Huh? Did you notice that? Mm-hmm. Okay, so I did the ASIS and shifted the pelvis. Really helped the left one. Partially helped the right one. So is there a little more? This is GPA. This is when you can learn this and get an innate feeling and finally go over and over and over so many times where their innate starts talking to you. Your innate saying, hey, how about this? Hey, remember this. It'll tell you. People say, Doc, how do you know that? I don't know, it just told me. Okay, his energy is communicating with my energy with his. I think he trusts me because he's here. So silently, I was told, check the right pubic bone. Okay? Bend your knee. I need to touch right here, okay?
Okay.
Okay. Tender.
Uh-huh.
Okay? Bend your knee. Not tender.
No.
Okay. So, in palpating the pubic symphysis and the pubic bone, the right pubic bone is elevated. Okay? Minor thing, but again, he's restricted on this side. And that's 40 degrees. It ain't 70 like the other side. So, oh, never mind. I'll do the best I can with that. Okay. Tap here. Okay, I tap. Pubic bone. I tap. No, I don't push. I sit and I tap. Okay, now. Still painful?
No.
Not more. No more pain. Are you sure? You're not being nice to me, are you?
No, I'm not being nice.
Okay, he's not being nice. Okay, it's no longer tender. I shifted the pubic bone, put it in place because I did the whole pelvis first. Could I have shifted the right pubic bone first, then done the pelvis, yeah, you probably wouldn't have got the result. But since I felt both hips locked in internal rotation, I wanted to do the pelvis first, ASIS, anterior superior iliac spines. Then the remnant is, I got a pubic bone. So let's see, bend it. Um, 60, all right, not quite the other 70. All right, so I got some functional stuff left here. So I'm going to go in external rotation, push me off. Not so good, huh? Push, good, relax. All the way, push. You want that muscle to fire, it quit firing, push. Good, now let's go neutral, push. I'm isolating certain muscle groups, push. Push, good. All right, internal rotation, push. Relax, let me have it. Push. Good. Let's go back and external. Push. Yeah, external is still a little slow, but let's just keep firing it. Push. Ah, that's it. Push. Why am I doing that? I'm sending messages to the brain. Brain, I want you to fire this muscle. I don't know how. I haven't been doing that. It's been locked up. Well, brain, work with me and learn how. So I do repetitious. External rotation, neutral, internal rotation. Have them keep firing it. Not just fire it from, okay, not from this fire. I extend, stretch the muscle to its max, make them fire at the end of the origin and insertion. Make both of them fire, okay? And hopefully, bend your knee. When we do this now, we got the 70 degrees. And we can go all the way out here. Completely different, right? Yeah, okay? So now that takes care of his pelvis. And come on, sit up for me, sir. And there's no charge today, by the way. Okay, sternoclavicular joint. It's maybe a little high on the left, but pretty good. Ribs, symmetrical. Below the clavicle, second and third ribs, they're symmetrical. Okay, I get a little bounce out of them. The first 6 ribs are bucket handled. So your lungs can come up and breathe. Okay, so just touching them, flat, touch them easy. Okay, they're bouncy, they're working. All right, my opinion. Come up here to the first and second rib. Right, is that a little tender?
Yep.
And is that tender?
Not as bad as the left.
Yeah, the left, you got a left second rib. Does that go along with everything I find here? Yes. Does that go along with the occiput being out of alignment? Yes. Okay. Scapulus, are they even, doctor?
Similar to the left, it's a little high.
Touch high on the left. So let's do a left. Actually, why don't you face that wall and I'll try to do
This
demo.
wall?
No, this wall over here. See? Still look high, Jerry? Can you see it here?
You need to move your body a little bit. Yeah. Okay.
All right. And still got the second rib?
Yep.
Yeah. Okay, now let's see. Lean to the left. 1, 2, 3, 4, 5.
Even.
What? Even?
Even.
Can you see it, Jerry?
Uh-huh.
All right, even. Okay, now I put the wedge in here. How's that feel?
It's not as tender.
Not as tender. Because I just adjusted the rib with the wedge. The body is self-adjusting. So for me, all I got to do is come in and tap the rib. I missed it. Tap the rib in. Bucket handle, right? Bucket handle. If he had 4 ribs out here, come into the office, I'm hurting up in here, Dr. Vetanze, what can you do for me? Let me knock your ribs in. Without doing anything below the ribs. These ribs are out of alignment because, and they're being either caused by or aggravated by what's happening at the foot foundation because everything's twisted. So I don't want to just come in and do the ribs because it ain't in right order. And I'm going to hurt you. So, anything?
Definitely better.
Definitely better? Even. Okay. That's the adjustment. Kind of hot in here, everybody. Sorry, I'm sweaty. That's your first adjustment, doctor.
All right. Appreciate it.
You're welcome. Thank you.
Learned a lot. Thank you, everyone, for.
And questions?
I got a lot of questions.
All right.
I mean, biomechanically, structurally, I want to understand why what you're doing works. Why does it make me feel better? I'm used to measurements in the spine. You guys are talking different languages, heights of scapula, heights of ribs, subjective things like, does that hurt when I push here, leg length, and honestly, when I'm hearing you go through this, and a lot of the stuff, you're probably talking a language that you're not familiar with, so I'm presuming your chiropractic viewers understand it all, but is there the sequence to when you're starting with the feet, going up to the sacrum, going back to the feet, going to the occiput, going back to the feet, and then we're sitting, you're making, what does it mean when one side is high, and how does that correlate? Is there an equation in your mind where you say, okay, the right leg is shorter, so the left shoulder could be higher, or is that just, I like the fact that you're thinking through it in a sequence. I don't fully understand the domino of that.
These chiropractors have been visiting me 3 or 4 times now, flying in from another state. This is Dr. Vihil's first time. I have ones, they come all the time to learn. Okay, now I'm going to answer that by asking them. You start learning, okay, Dr. Garner, Dr. Draper, come over here, please. 4 years ago or so, you started GPA.
Right. Correct.
You start performing GPA, okay, the more you did it, trying to understand basic pattern, and then what happens in a form of pattern where the innate intelligence, the body of the patient starts telling you stuff. Has that increased?
Absolutely. Absolutely.
Tell them how.
Well, when you're looking at everything and you see the differences when you lay first face down and you see the leg length and you know that they're out of alignment and you begin to correct it, and you see also that the body will show you other stuff once you've corrected some things, which is kind of unique. Because the way we're taught in school, that doesn't necessarily work that way. Because as you heard him talk about earlier, the side posture maneuver, I don't even do that anymore. Okay, I might put them there to stretch them a little bit. But once you go through the system and you do, for lack of a better word, a domino effect, because you're starting with the biped situation, you just start to see things bounce out because of what you're finding on them, and then it just leads you to the next thing the body does, and you correct it, and their pain is literally gone, or is significantly decreased after that. And one of the key points is the table. The table is a key point.
Absolutely. If you don't have a drop table, you can't do this. Well, Dr. Gardner, what's your opinion? Can you get it?
I've been experiencing the same thing. I think I got a good chiropractic education before, but once I found Dr. Vetanze at a seminar, I was just like, this all started making sense as structurally. And then as we became more and more proficient, at least for myself, I started kind of seeing what you have perfected and improved upon greatly. And now all of a sudden I call it like a GPA dance. The body starts talking to me, I know exactly. It hurts right there. And they're like, how'd you know that? It just
Have anything to do with innate intelligence?
Oh, absolutely.
Chiropractors understand that word. When that body starts trusting me, it reveals more. They don't talk to me verbally, but I sense, oh, this is next. And it just sort of comes to you, like maybe when you're a surgeon and you get in there, you're like, oh, I better do this. Kind of hoping is the right thing, right? Or, yeah, okay. Much better, much more important thing than we do. But it just sort of like, oh. So, Dr. Vihil, what do you think?
Yeah, I've been doing this now for pretty close to a year, but kind of wanted to expand on, like, we have the GPA protocol and the pattern, and so you're trying to understand it, how we're going from the feet to the sacrum and back and forth. The innate response to that, as things are being moved, just as they put the pelvis underneath your wedge and you started moving, nothing had even been done. just that innate change in the body. lets us go back to the sequence. So the sequence is the protocol, but it kind of changes based off of the innate response to the body. So it's not like I'm following it specifically every time. Hey, you see when I put that there? Now this is all of a sudden different. We still have a pattern to follow, but now we got to go with the change of what is happening because we initiated just a wedge push, or you turned your head to the left, or you turned your head to the right. So just following that over the protocol over and over, the body reveals, hey, this is what I want next. If I try and adjust something or maneuver something without you having turned to the left or right because I don't really know it, before GPA protocol, kind of what I've been taught over the last before 20 years that I've been doing this, we can actually maneuver it, adjust it, and make it move. It's not as always comfortable. We've all had those adjustments where like, ouch, that's a little bit ouchy from the client. Sometimes chiros do a little bit too much force. We get it to move, wasn't comfortable. Next thing you know, you're coming back and seeing me, I still got the same problem, I still got the same problem, I still got the same problem. How come? Because we haven't innately figured out that didn't want to move yet because we got something in the sacrum that needs to be moved first to let the rest of the body start lining up.
And the more you work with it, the more is revealed to you. Your first year as a surgeon,
Sure.
a little different than now.
Absolutely.
Absolutely. And basically same thing. The thing is with chiropractors, you got to get started sometime. There's a manual, there's videos online. It's Jerry, correct me, chiroguru.com.
TheChiroGuru.com.
TheChiroGuru.com. You'll see it on the screen, I hope. And it's Dr. Brent Kimball.
That's right. I've got a YouTube channel, been growing some content, The Spine Doc on YouTube. And just, you know, if you want to understand a little bit more about what I'm doing or what spine surgeons, I can't speak for everyone, but what I'm thinking about, addressing topics in spine that are at least relevant to me and hopefully relevant to my patients and to you, I think that's, you know, a starting point for expanding the conversation. I think we need to do more of these, more topics, and I mean, we talked about a bunch of stuff before we started this this adjustment and this review, but we could do a ton of different topics and just go through, well, this is what I'm thinking, what are you thinking? How would you address this? Well, this is how I'm looking at it.
That's the way it should be.
Yeah, unless you know how I'm approaching it, you discount the validity of everything that I'm doing, and I'm discounting the validity of everything that you're doing because I'm not even attempting to understand it.
Exactly.
But, you know, to say, well, you know, all surgery is bad, or if you've never seen it, you've never watched it, you know, you watch these things, these adjustments and subjective improvements and objective measurements are changing. When we're doing surgery, we're actively looking at the nerves, we're looking at the spine, and we're looking for actual changes. And to believe that that happens or not, you kind of got to see it to believe it. There's a reason you do what you do because you get results. And there's a reason that we do what we do because we get results. Where do those come together?
Yeah.
That's what we want to explore, and that's what we want to find some synergy in, right?
Well, your website is
Your
YouTube?
Yeah, so the YouTube channel is The Spine Doc.
The Spine
You
Doc.
can find me on Facebook too,
Yeah.
Dr. Brent Kimball, pretty easy to find.
Well, you know, in my opinion, you're the best surgeon that walks. What he has done with my referrals has been beyond acceptable neurosurgery. It's way in the miraculous realm. This last patient, you like rebuilt his whole lumbar spine. Well, I can't say his name, right?
Yeah.
And after 5 surgeries or whatever, he fixed him. And he showed me the MRI. I looked, what is that? It looked like something I would buy at the store, you know, because there's no more. It's not like it was. Okay. He fixed me L4, L5 when I had a 4 millimeters in stenosis and I was in miserable pain. Boom, fixed. Many cases. So this is to me the top surgeon, and he's I believe one of the top chiropractors. We can do a lot. So if we can help you, this is not a business thing. We can help you. Ask us. Call us. Ask us questions. I get numerous calls, numerous emails from all over the country, world. Okay. I love you all. Dr. V, the Chiro Guru. God bless. Thank you for being here. Goodbye.
Thank you.
I love you, man.
You too.
Okay.